There are some questions, and I would like to invite the panel. So obviously the speakers and my co-chair from this session, but also Professor Katia Belardo and Professor Francesco D'Antonio to join the panel discussion. That's the last panel in today's program. And there are some already questions. I'm going to start with one of them. It's about actually the follow-up of these babies. So let's say a fetus you diagnose with complete agenesis of corpus callosum. The woman is continuing the pregnancy. You've done your investigations, and the baby is born. What assessment does the baby have, or is it actually depends on the symptoms? So if they didn't have genetic workup during the pregnancy, do they automatically do it, or do they do EEG, for example, or it depends on the symptoms?
Yeah,
and that's open to everybody. I mean, Kasia, I think we have a treat for having you joining us today. It's wonderful to have a neurologist joining the panel discussion when we talk about neurosonography. So please go ahead. You're the expert.
Yeah, that's great. Often I get called when a baby with isolated CCA is being born, and I'm always really triggered by the neonatal neurological examination, because when you look at the reflexes of a baby with an isolated corpus callosum agenesis, they have really, really high reflexes. When you make a tendon knee reflex, you will see a reflex of 8 pulses going on, and also the ankle clonus is really really highly elevated, and that disappears only about 3 to 6 months. Then you see the reflexes going down, and that's actually only the case in complete callosal agenesis and partial, and not actually in the more dysgenetic callosal anomalies. So actually, you can turn it the other way around. When you see a baby with really high reflexes, always think about the corpus callosum. And so should you do an EEG? No, you don't need to do an EEG if it's just an isolated agenesis. You just can look at the baby and see how it goes. And should you always do an MRI? I think when no fetal MRI has been done in the late 30s gestational age, then I would advise to do a fetal MRI as well to pick up the additional anomalies.
And do you do routine genetic testing? So if the patient did not have prenatal genetic test, do you offer the parents the option of postnatal genetic testing?
Yeah, you always offer it, but of course they don't need to accept it. But yeah, we offer it.
And I guess if you do it, you do whole genome or you do whole exome?
In the Netherlands, we do a whole exome, and whole genome is still on research base.
Okay, fantastic. Lovely. Thank you very much. I mean, please, for the rest of the panel, I mean, please add if you want to have any comments or suggestions or anything you want to add or disagree with. So please just join. Another question, which is very few studies, mostly abstract or small series, which suggest that we should also check prenatal brain imaging when facing with brain anomalies, especially ventriculomegaly or AC. Do you think we should extend imaging assessment to parents? So sometimes you say, okay, well, the baby has ACC, isolated, appear on ultrasound scan or the MRI. Well, should we maybe test one of the parents in case the parents have the same, the parents appear to be normal, and therefore would be hopefully have good prognosis to the parents? Do you routinely image the parents?
If I take the question, no, we don't do routinely. Sometimes, because we always ask a family history, and when we see signs of autistic features or then we have the suspicion that it can be an autosomal dominant trait, and then we advise to do an MRI scan in the parents as well if they would like to do that, of course. Especially the DCC gene is often an autosomal dominant trait, and then you find it back in one of the parents. So we do it, but only on occasion.
Okay, and I mean, I don't know whether the practice varies. I mean, obviously because we mainly manage the patient prenatally. What is actually, is there like a consensus on how a protocol at what age you follow up the babies? If they are okay, do you see them in 3 months? Do you see them in 6 months? Do you follow them up for the rest of their life if you already know that they have ACC, for example, or do you stop at certain age?
Yeah, it's a really important question. And I think we really should join forces in Europe to have better long-term outcomes, because that is one of the most important questions we have actually when we are doing counseling. At this moment in the Netherlands, we see them until the age of 8. And the most problems are being encountered between the age of 5 and 6. And then you see that they remain, that they have behavioral problems, that they have the autistic features come out, and also the intelligence, whether they could go on to the next grade, is often a problem. So, and that's the most age. I think at least you should see them until 6. Yeah.
6 years.
Yeah.
I mean, I think we're on Italy. I mean, Francesco, do you know do you know whether the neonatologist or the pediatrician in Italy, do they do something differently? I don't know what in the UK, but I suspect it's similar to the Netherlands. Francesco, if you know whether they do something differently, or maybe you say, well, I don't really know what's the protocol in Italy. Do you want to comment?
Yeah, so I will also comment that the fact of doing parental imaging, because I would have replied no, but then we have more or less 5 to 6 cases in a row in which the first one that the baby has a thick corpus callosum with normal parts, and we did the genetic test, and there was so it's not a single gene anomaly, a class 3 gene anomaly, which was actually so parents of maternal inheritance, and we did MRI to the mother, and the mother corpus callosum was very thick, but the mother was a lawyer or something similar. And then we had another cases of ACC in which the father has ACC too, and there was another one of ventriculomegaly in which the father has 27. So the size of the ventricle, one of the ventricle was 27. So I'm starting to reply that perhaps we should at least considering that. I don't know how it will be justified. So I don't know how. So the cost might be justified by such an assessment, but in some cases there is a concordance between fetus and parental brain status. I think that the future implementation of genetics in fetal medicine will tell us more on how to actually tailor this parental assessment. And regarding the neonatal assessment, I'm afraid to say that there is a great variability in Italy, because in most of the cases, such cases are lost. It also depends on the socioeconomic status of the parents, because most of them, at least so the national health system will ensure a continuous assessment of these babies, but in most of the cases they are lost or they are forced to do to private doctors. So in Italy, there is a national health system, but for some specialization, there is a lot of private. And I would say, I'm afraid to say that most of these cases are lost after actually the normal follow-up, whose length is about 3 to 5 years. So I'm afraid that the longitudinal long-term data, at least from our country, is different to get, at least from my area. I'm not just talking about the entire country. But I'm not a neonatologist, so I don't know how to structure a formal follow-up assessment, because they are very strict in the first months, which more or less I don't know how useful might be. And then actually they progressively lost these babies.
Interesting. So Kasia, I hope it's okay. We're asking you so many questions, but I think, as I said, it's a treat to have you with us today. So we're really using this fantastic opportunity to learn from you. So one of the commonest questions that the parents ask, and I often fail miserably in answering it properly, is when you say, oh, there's a baby that might have risk of disability. And their question is, what do you mean by that, doctor? I mean, what the problem would the baby have? And I think I struggled really to tell them exactly. I said, well, it varies in the severity and it might be this. And so ACC, you did say it's mainly really cognitive, it's maybe behavioral and maybe autistic, but do they have epilepsy and do they have any motor symptoms?
Yeah, most of the time epilepsy is not on the foreground. So sometimes it occurs, but it's a really small percentage of cases. So I wouldn't actually counsel it when I tell it to the parents that there is an increased risk for epilepsy. We see some motor problems, but it's more in the fine motor. So like nicely writing and things like that, or swimming. So the joint movements that you have to incorporate, that are sometimes a problem. But in the real motor, like developments like walking and sitting, you hardly see any problems.
Okay, that's really interesting. And maybe if I bring the team, Zumela and Boka, because I think you did have a really nice slide with about the prediction of the neurodevelopmental outcome. So, for example, we know that ACC, let's say 30% risk of neurodevelopmental delay. And of course, if it's non-isolated, the risk is much higher than that. Can we tease out the patient in front of you, this individualized risk assessment? Is she going to be in the 30% or is it going to be in the 70%? Is there any way of trying to, is it imaging or maybe follow-up imaging during the pregnancy that can maybe help us, give us clues about to help these parents in their decision and the preparation?
Yeah, good question. I think it's actually difficult because in the Netherlands, we have a termination level at 24 weeks. And at that moment, you cannot have good neurosonography like you can do on the third trimester, which will give you more information. So we are mainly limited in that. And I think it's what you can do at around 20 weeks is to see, are there any other anomalies? Do they have genetic testing? We do WES in that case. So that's, I think, the most we can do, and then see if they are in that group of isolated, but still with the limitation that there might be some additional anomalies after birth, or that they are in the higher group.
Okay, fantastic. And we're going to go to Kasia and ask for help again. Is there any clues that help us in terms of, because when you counsel these patients, do they ask this question?
Yeah, of course they do. And that's maybe a very good point, because I really would like to make this point, because of course I'm a neurologist, of a pediatrician neurologist, but all the prenatal things and the prenatal development. So I really would I think it's a really good idea that we counsel those parents together. So the fetal specialist together with the perinatologist, and I think that, and also actually I think that the fetal neurologist should be present at the ultrasound as well, because together more. So I would plead for that as the first thing. And the second thing, I think it's really important that we go off the 70-30 percentage of good and bad outcome, because I just are doing fetal MRI, or a lot of us are doing fetal MRI, and if you don't find any additional anomalies, then I think the 70-30 is already going to 80-20, or in case of callosal agenesis, maybe, and you use the Dioco score and already to 85-15% of bad and good outcome. And if you have done an exome sequencing done, I think then you narrow down the bad outcome to 10%. So I think we should use a more stepwise approach in counseling the parents. So not stick to the 70-30 as we did in the
all days.
Tailorize it.
That's extremely helpful. I think you did ask Gregor, I think, about the score. And if you don't mind, can you just maybe explain it to us? Because I think it will be beneficial to everyone, including obviously the delegates, to just tell us about the score.
Yeah, it is an 11-point score in which you judge the callosum on the fetal MRI. It's especially helpful between 22 and 30 to 33 weeks of gestation. And if the score is below 4, so 0 to 3, then you generally have a good outcome. And if the score is 4 or higher, then you generally have a bad outcome or you have associated syndromes. There are a few genetic anomalies that are not always, so you can have a low Diogo score and, for instance, a DCC genetic anomaly. And also Coffin-Siris patients sometimes have a low Diogo score. So it's not working 100% perfect, but you can increase the percentage of bad and good outcome fairly.
Okay, and before I hand over to Miller for to sort of ask questions as my co-chair, can I just ask sort of, so that's what you mentioned about the score and the outcome or the significance of the score, but what does actually the score include?
Okay, yeah, probably Bauke can explain because she nicely showed it on the talk.
Yeah, you mean about
The Diogo score.
high or good outcome?
The Diogo score.
Yes. Yes. So what they checked the score. So they had the items Kasia mentioned. They were assessing the children after birth, and they when it was a low score, it was a poor outcome. When it was up to 3 points, and when it's 4 higher, you have a good outcome, and that they try to relate to the imaging via fetal MRI. So in that case, perhaps you can predict more if you are in a more favorable or more poor outcome.
So that's using the MRI imaging findings to correlate with the score.
Exactly. Yeah.
Okay. Okay, I have to admit, it's not something that we do use routinely. I don't know whether other people, do you use it routinely?
Yeah, we are discussing this with our neuroradiologist. So it takes time to implement it, and we have to see if we can really work out, and if it sounds really good if we can do it, but if you can actually rely on it, yeah, we have to see. I think
well, we have to validate it. At least we have to try. Okay, so I'm going to hand over to Miller because I think she's my co-chair and sort of
So, Bauke, you underline the need for long-term follow-up studies. I think also in this discussion we already discussed that there's only scarce data and for long-term follow-up. Can you give any recommendation for that?
Well, I think it's important to have well, if you want to discuss true isolated cases, then you need to have data on patients who have the abnormality, but with genetic testing and preferably the West whole exome sequencing in combination with a fetal MRI and then standardized follow-up and also after birth. So in case genetic testing was not done, you can do it after birth and neurosonography, MRI, and standardized follow-up. And if we can do that standardized with a outpatients clinic with neonatology and pediatric neurology, that might give us, I think, more information, because if we look at the literature now, I think a lot of cases that are classified as severe might end up with still a syndrome or some underlying cause. So perhaps it's not severe in case of an isolated complete pulse sclerosum. I don't know, but that might be. And then when you follow up, you have your longer follow-up time, we see that when these children are older at a later age, we see more abnormalities. So perhaps that burden is larger than we see now, but that takes time. And again, I think also that we should collaborate to get these numbers, because it's not easy with the numbers we have in only one center.
Yeah,
I think Kasia will agree with that, but Bauke, until what age would you recommend to do a follow-up, and can you also comment on how we should do that follow-up? Because you also mentioned that in the literature, different tests are being used and different scores to test the developmental follow-up.
Yeah, that we should. That's also in our center. We work together with the pediatric neurologist, so we counsel together. But also they see the patients on the standardized moments. But that's also for the pediatric neurologist to agree on which test is the best to use. And of course, the best is after 5 or 6 years, but at school age or even later, you want to follow them, I think, until 18 years, more or less. But the problem at that moment is there will also be a lot of other factors that will probably have influence on how you will develop. So it's challenging, I think. But we should try.
And Kasia, what is your opinion? Until what age should we ideally perform a standardized follow-up, and what tests would you recommend?
Actually, at this moment, we are doing a joint research together with Vienna and Oxford and Southampton and Leiden data. And we are looking at a few hundred callosal anomalies, and we're looking for long-term follow-up and how we can predict outcome better. What we do is we do AIMS testing until age of 1, and then we do at 2 years the Bailey scales, and then at 5 years the motor movement ABC and the CBCL testing across all ages. Then we start with the official IQ testing, like the WISC. Before the age of 5, you can do the WIPC. So that are the normal tests that are done to see all those things. And I think, I agree with Bouke that we should actually, probably you would like to see them at the age of 18 to see how they are socially. Do they have a partner? Are they going to study? Do they find work? And that would be really interesting to see that as well.
Well, in a way, it's really worrying that we are basing our counseling and also our decision-making on data that are collected mainly retrospectively and from studies that are very heterogeneous. So I really think that this should be a call for a collection of good quality prospective data. Because, well, I know that for us, let's say fetal medicine doctors, the worry is to prevent the birth of a child with a limitation, with a handicap. But for you, postnatal doctors, neonatologists and pediatrician is more well, to make the best out of the baby that was already born. So there is really a kind of a major contradiction, a major, let's say, dilemma in the way we approach the patient. And unfortunately, we have to deal with data that are suboptimal in our prenatal counseling. So I really think you have there a mission to promote the collecting of good quality data.
I definitely would echo that, Katia. I mean, I think sometimes when you try to look at the studies, I think that the limitation is in fact how you actually, so the problem, each study will have small numbers because we're talking about rare anomalies, correct? And it's difficult even to put a large study, multi-center, they all had the same assessment, the same methodology, same protocols prenatally and followed up at the same time using the same tools, the same methodology. So I think it's just difficult. But also, on the other hand, I agree with you, Katia. It's not something that we can control because we deliver baby and hand it over to you. And Katia, you're absolutely right. I mean, one of the major issues to reduce the risk of delivering baby with a disability, but also I think equally, increasingly, I feel that our duty also to stop terminating babies who are okay. Yeah. And I think, like, listening to Kasia, when she say it's not 30-70, if you've done the exam and it's okay, let's go to 20-80. And if you actually repeated the MRI and it's okay, or sort of, there's not other associated abnormalities, this may be less. So I'm increasingly thinking, well, actually, 30-70 is a bit of a irresponsible behavior where actually we're becoming a bit more defensive. We don't want to take the responsibility of a baby that has a disability.
There is a last question. I don't know if you've seen it. a delegate who is asking, can dyslexia be seen in the brain? I think that we all know this, the answer, but please, Akasha, if you want to.
Unfortunately, we can't see it. No. So there are a lot of things in the brain are networks. And so how things in the brain work together. And unfortunately, we can't see it. Maybe in the future with functional MRI or things like that, that will be possible. But until now, not.